Concepts of Oncology, a channel exclusively for learning about cancers. Subscribe for new videos every week.
What is the new theory of epithelial ovarian cancer origin?
Earlier, it was believed that epithelium ovarian cancer arises from outer lining of ovary. Now is it believed that high-grade serous carcinoma, the most common type of epithelial ovarian cancer, originates from epithelial cells of fimbriated end of fallopian tubes. These epithelial cells may enter ovary through breach in epithelium of ovary when ovulation occurs. This is called endosalpingosis. Lining of peritoneum, lining over ovary and fallopian tube are all part of coelomic epithelium. Hence, primary peritoneal cancer, ovarian cancer and fallopian tube cancer are considered under one group.
What are different types of ovarian cancer?
Ovarian cancer can be broadly categorized in two groups, epithelial and non-epithelial type. Tumor may rise from epithelial layer of ovary or may arise from stromal cells. Epithelial ovarian cancer is broadly classified in serous type and mucinous type, with some other rare variants. Non-epithelial tumors histology depends on type of cell of origin. Germ cell tumors, granulosa cell tumors, theca cell tumors. In this video, by default ovarian cancer would imply epithelial ovarian cancer as it is a most common ovarian cancer type. High-grade serous carcinoma is the most common histology. Low-grade tumors in ovary are rare. Borderline tumors are special entity, lying between benign and malignant. They do not metastasize, and there is no role of adjuvant chemotherapy, hence surgery is curative.
Is there any hereditary predisposition for ovarian cancer?
There is an increased risk of ovarian cancer in women with a family history of breast or ovarian cancer, as well as in families with Lynch syndrome. Although most epithelial ovarian cancers are considered sporadic, at least 10 to 14% of patients have a germline mutation in BRCA1 or BRCA2.
Can we screen for ovarian cancer?
There is no proven effective method of screening for ovarian cancer. At present, routine annual pelvic examination, CA-125, transvaginal ultrasonography or combination of these as screening tests suffers from high false positivity. High false positivity in screening tests are undesirable, as it may lead to unnecessary anxiety and surgery. These tests are even not effective in high-risk populations where risk of ovary cancer is high, like in BRCA. So in high-risk cases, like BRCA, prophylactic bilateral salpingo-oophorectomy is indicated. It will be protective for both cancer ovary and cancer breast. As removing ovary decreases estrogen levels, decreasing chances of estrogen-dependent breast cancer. It is important to remove both ovary and tubes as high-grade serous cancer develops from tubes. Even after salpingo-oophorectomy, there is still risk of primary peritoneal cancer.
What are the clinical presentation of ovarian cancer?
Majority patients with ovarian cancer have vague pelvic, abdominal, and menstrual symptoms. For this reason, patients with ovarian cancer often present late. The so-called classic triad of clinical features associated with fallopian tube cancer, watery vaginal discharge, hydrops tubae profluens, pelvic pain, and a pelvic mass is present in less than 15% of patients and is more of historical interest. Most important signs of ovarian cancer is hard pelvic mass, especially if associated with ascites.
How do you investigate a case of suspected ovarian tumor?
Various important investigations to be done in case of ovarian tumor are transabdominal USG, transvaginal USG and pelvic MRI to better characterize the adnexal lesion, CT scan abdomen and pelvis to find any other site of disease, PET scan. PET scan is usually done in undiagnosed pelvic mass and in cases of advanced disease.
Are there any tumor markers for ovarian cancer?
Markers of epithelial ovarian cancer are CA-125 and human epididymis 4HE4. However, CA-125 is non-specific marker with raised levels even in benign diseases like endometriosis, PID, tuberculosis, etc. If patient is young, then there is chances of germ cell tumor. Human chorionic gonadotrophin, lactate dehydrogenase and alpha-fetoprotein is done to diagnose germ cell tumor. Serum inhibin is specific tumor marker for granulosa cell tumor. Important point in using CA-125 is that rise in benign diseases is usually mild in comparison to malignant. However, CA-125 levels are not raised in mucinous tumors. In differentiating benign and malignant mass, CA-125 CEA ratio can be used. Ratio more than 25 in adnexal mass is more likely malignant.
What is risk of malignancy index?
The risk of malignancy index, RMI, first described by Jacobs in 1990, is one method of differentiating between benign and malignant masses. Utilization of this index may facilitate better triage of suspicious pelvic masses. The RMI incorporates the menopausal status, an ultrasonic score, and the serum CA-125 level. An RMI of more than 200 in an adnexal mass is highly probable of cancer, and such patients are taken up for surgery.
Ovarian cancer staging is unique among all cancers in human body. So how do you stage ovarian cancer?
FIGO staging is recommended for ovary cancer. Broadly, Stage 1 is limited to ovaries, Stage 2 limited to pelvic cavity, Stage 3 is disease in pelvic nodes or beyond pelvic cavity and upper abdomen, Stage 4 beyond peritoneal cavity, like in pleural cavity or hematogenous dissemination. It is easy to characterize Stage 4 and 3 disease, based on pre-op extrapelvic or extraperitoneal disease on imaging and cytology. Main problem in actual staging comes with Stage 1 and Stage 2. Ovary cancer has a very unusual way of spread, transcelomic spread, means cells shed in peritoneal fluid and then they are carried away with movement of fluid due to diaphragmatic excursion. These cells may deposit anywhere in cavity, omentum, peritoneum, bowel serosa, mesentery. Hence even when gross tumor is in pelvis, disease may be in whole abdomen in form of microscopic deposits which are diagnosed by biopsy only. So, a very important point in staging of ovary cancer is that it is based on findings at surgical exploration, so final stage is decided after surgery. Abdominal viscera like liver may have two types of ovarian mets. One is deposition of exfoliated tumor cells on surface capsule. These are surface mets. Parenchyma is not involved. Another route is blood-borne mets which involve parenchyma. Parenchymal mets are Stage 4 disease while surface mets of abdominal viscera are Stage 3. Surgical staging should be performed because subsequent treatment will be determined by the stage of disease. In patients in whom exploratory laparotomy reveal any macroscopic evidence of disease beyond the ovaries, an attempt for complete removal of all gross disease is done. This is called cytoreduction. In cases where there is no macroscopic disease beyond ovaries, a careful search for microscopic spread must be undertaken.
So actual ovarian cancer stage is decided by surgical staging. So what is surgical staging?
Following are the steps of surgical staging. Any free fluid, especially in the pelvic cul-de-sac, should be submitted for cytologic evaluation. If no free fluid is present, peritoneal washings should be performed. A systematic exploration of all the intra-abdominal surfaces and viscera should be performed. Any suspicious areas or adhesions on the peritoneal surfaces should be biopsied. If there is no evidence of disease, multiple intraperitoneal biopsies should be performed. The diaphragm should be sampled either by biopsy or by scraping with the tongue depressor and making a cytologic smear. The omentum should be resected from the transverse colon, a procedure called an infracolic omentectomy. Evaluate the pelvic lymph nodes. Any enlarged lymph nodes should be resected and submitted for frozen section. If no metastases are present, a formal pelvic lymphadenectomy should be performed. The para-aortic area should be explored. Any enlarged nodes should be removed and at least the nodes caudal to the inferior mesenteric artery resected. Once surgical staging is done, biopsy report will decide the final stage. Many cases of clinical Stage 1 turn out to be Stage 2 or 3 after completion of surgical staging.
What is optimal cytoreduction?
In advanced stage ovarian cancer, optimal cytoreduction is the aim where every attempt is made to remove all gross visible disease. Earlier, optimal cytoreduction was defined as non-residual deposit more than 1 cm, but now, it is seen that in patients who have all gross visible disease removed have better survival. So now optimal cytoreduction in ovary cancer is defined as removal of all gross disease.
What is the stage-wise treatment for ovarian cancer?
The primary treatment for Stage 1 epithelial ovarian cancer is surgical, that is, a total abdominal hysterectomy, bilateral salpingo-oophorectomy, and surgical staging to confirm that disease is limited to ovary. In case where advanced stage disease is diagnosed preoperatively by imaging, upfront surgery and all attempt to achieve cytoreduction is done. If not possible, then neoadjuvant chemotherapy is done to decrease bulk of tumor and facilitate optimal cytoreduction. In stage 4, main treatment is chemotherapy. Main active chemotherapy regimen is combination of a taxane and carboplatin. Taxanes like paclitaxel and docetaxel dosing is calculated according to body surface area, but carboplatin is unique in that its dosing is calculated using multiple parameters like creatinine, age, weight and area under curve. This is balancing plasma concentration of carboplatin according to renal clearance to avoid higher concentration of drug in plasma. Stage 1 disease is further classified as low risk if stage 1A or 1B with grade 1 or 2 is present and no clear cell histology is present as it is aggressive variant. In these cases no adjuvant treatment is given. Rest stage 1 high-risk cases are given 3 to 6 cycles of chemotherapy. Advanced stages 2, 3, 4 are given 6 to 8 cycles of chemotherapy.
What is role of neoadjuvant therapy?
Neoadjuvant chemotherapy may be given before surgery in selected cases. Those patients who have a poor performance status, such patients usually have large volume ascites and are a large volume pleural effusion, and will be poorly nourished, with a low serum albumin level. After 2 or 3 cycles of neoadjuvant chemotherapy, the effusions will usually resolve, the overall medical status will usually improve, and the interval surgery will be better tolerated.
What is HIPEC?
Since ovary cancer cells exfoliate and spread through peritoneal fluid, therefore it makes sense to give intraperitoneal chemotherapy. After cytoreduction, chemo drug is instilled in peritoneal cavity and left for some time to absorb through peritoneum. Raising temperature can increase absorption by increasing vasodilation of peritoneal capillaries. HIPEC, intraperitoneal chemotherapy, is associated with an increased overall and PFS in patients with optimally debulked stage 3 ovarian cancer. Since HIPEC is for microscopic disease, so it is indicated in cases where optimal cytoreduction have been achieved.
In a young woman with ovarian cancer, if patient wants a child, is there any role of fertility-preserving surgery?
Fertility-preserving procedure may be considered for patients with stage 1 ovarian cancer, mainly stage 1A and grade 1 and grade 2.
What is platinum-sensitive, platinum-resistant or platinum-refractory disease?
After adjuvant treatment, patients are followed, and then when recurrence occurs, they are classified as either platinum-sensitive, platinum-resistant or platinum-refractory. Platinum-sensitive ovary cancer is when after completion of treatment there is more than 6 months of disease-free interval before recurrence comes. Since recurrence appeared late, hence it means that disease was sensitive to platins. Platinum-resistant disease is when disease responds, but recurrence occurs before 6 months of disease-free interval. Platinum-refractory is when disease progresses despite chemotherapy. In cases of platinum-sensitive disease, again platinum-based chemo is started, while in platinum-resistant and refractory, second-line chemo drugs like gemcitabine, etoposide, liposomal doxorubicin is given. Concepts of Oncology, a channel exclusively for learning about cancers. Subscribe for new videos every week.